You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract. Hello and welcome back to another episode of Beyond the Abstract. We appreciate you taking the time to stop by. Today we're sitting down with doctors Nicole, Malette, and Paxton Bach to discuss their article, Medication Approaches for Patients with Opioid Use Disorders, Differences Between Primary Care Clinics and Specialty Addiction Treatment Programs, which is featured in the current July-August issue of the Journal of Addiction Medicine. Dr. Malette and Dr. Bach talk about benzodiazepines in the unregulated opioid supply and how it has impacted the toxic drug crisis in Canada, as well as co-benzodiazepine/opioid withdrawal and how it can differ from regular benzodiazepine withdrawal and opioid withdrawal separately. But first, as always, let's learn a little bit more about our guests. Dr. Nicole Malette is an evaluator with expertise in health services research, education, and evidence-informed decision-making. She currently supports evaluation activities across programs at the British Columbia Centre on Substance Use in Canada, and her work focuses on using data to enhance substance use education programs, improve health outcomes, and support meaningful system change. And Dr. Paxton Bach is an assistant professor in the Department of Medicine at the University of British Columbia and a general internist and addiction medicine physician at St. Paul's Hospital in Vancouver, British Columbia. He serves as the co-medical director for the British Columbia Centre on Substance Use and is the holder of the UBC Diamond Foundation Professorship in Addiction Medicine and Recovery. His research interests include clinical trials in addiction medicine, novel treatments for opioid and stimulant use disorders, and innovations in overdose prevention and harm reduction. All right, now let's get into today's episode. And I want to start where we usually start with our podcasts, and it's at the beginning of the entire story, and that's addiction medicine. It's why this field of addiction medicine. So I would love to hear from both of you. If you'd kind of tell our listeners a little bit about what was it about this field that got you interested, and what have your experiences been like, throughout your career and up to this point so far?
Sure, I can start. So my journey to addiction medicine was a bit circuitous. I always knew that I wanted to work in urban health and work with disadvantaged populations. And I came back to Vancouver, where I did my internal medicine residency, with the intention of working at an urban hospital and working with some pretty marginalized populations. I thought that I wanted to do a fellowship in HIV medicine and really pursue that direction. But my experience during my training was in the early 2010s. And it lined up with the arrival of fentanyl in Vancouver. So I started to see fentanyl arriving just as I was getting to the later years of my training. And it really, I think, changed the direction of my career because it became very evident where the challenges were. It became very evident where the unaddressed needs were for my patients and what was causing the most harm. And it also became really evident where there was opportunity to really push the type of care we provide forward, to really advocate for the patients that I want to work with and do good medicine to really make a difference in their lives. And so it ended up being a fairly late stage decision in my training pathway, but I pursued a fellowship in clinical addiction medicine and I haven't really looked back. And subsequent to that, my kind of entry into research in the world of a clinician scientist was driven by the same sort of needs and opportunities. It was very obvious that there was unaddressed gaps, that there were questions to be asked, and that there were answers that were within reach and that could directly impact the care we provide and the lives of the patients that I work with. And so it became sort of an obvious choice for me, and I love the work that I do.
And I ended up getting into this kind of work in also a roundabout way. So I originally was working in academia. My background is sociology. And I was doing a lot of work in mental health spheres and education. And wrapping at the end of my research work and work in academia, I wanted my work to be more applicable. And at that time, it was 2020 that I was wrapping up. And we were in the health emergency, and I wanted to work at the BC Centre on Substance Use because I saw that my skill set in research work could help. So I'm the evaluation specialist, and I work in clinical education and evaluating clinical education programming. So I'm just glad that I can actually contribute. And add something.
Love it. I want to ask you guys, I want to jump right into this document that was in the Journal of Addiction Medicine here, and talk a little bit about, let's dive right in. I want to ask kind of a two-part question. How can you speak a little bit to how the emergence of benzodiazepines in the unregulated opioid supply have impacted the toxic drug crisis in Canada? And also what led you to assess the clinical challenges that are associated with treating benzodiazepine withdrawal in patients following discontinuation of unregulated opioid use?
So I can take a stab at this, and maybe Paxton can fill in any gaps that I miss. So first, it's led to an increase in overdose severity and mortality. So when combined with opioids, benzodiazepines can intensify sedation and respiratory depression, and that increases the likelihood of complex or fatal overdoses. It's also led to reducing the effectiveness of overdose interventions. So while naloxone reverses opioid effects, it doesn't reverse the sedative effects of benzodiazepines. So as a result, individuals experiencing an overdose involving both substances may remain unconscious or require additional medical support even after naloxone is administered. And the occurrence of benzos have increased the unpredictability of the unregulated drug supply. So right now, many people are exposed to benzodiazepines unknowingly because they're increasingly mixed into fentanyl and other street drugs. So this contamination makes it difficult for people to know what they're consuming, which is where our work came in. So if people are unaware that they're consuming benzodiazepines, management of opioid withdrawal from the unregulated supply becomes more complex and becomes a challenge for clinicians, which is something that was, I think, highlighted by a lot of our clinical experts and maybe some of Paxton's colleagues and Paxton himself.
Mm-hmm. Yeah, I would echo everything that Nicole said. I think this is, I don't want to be dramatic in saying that the arrival of benzodiazepines in the drug supply, at least in British Columbia, has been as significant a leap forward in the evolution of the drug supply as the arrival of fentanyl was in the first place. So just for context, we are one of the jurisdictions that I think has been disproportionately affected by this question. In BC, benzodiazepines have been a part of our drug supply, a prominent part since about 2021 now. And as much as 50% of the opioids tested in our province over the past 5 years have contained benzodiazepines, as many as 50% of overdose deaths are involved in some way, shape, or form benzodiazepines in addition to opioids and stimulants and other substances. So this has become an enormous problem, and really an unprecedented one. Not to mention the nature of the benzodiazepines that have arrived here, which are not ones that are familiar to me as a clinician. We're seeing things like atizolam and desalcohol-diazepam and flubromazolam and substances that I'd never heard of until now. So their arrival, I think, really caught us all by surprise. And as a clinician, I don't think we recognized early on the impact that was having for our patients and their day-to-day lives and what it meant to be out there using drugs. But I think we were delayed in recognizing the impact that it has on our own care, the care we provide, and the complexity of that care as well. And it became more and more evident that inadvertent exposure, unanticipated withdrawal, were extremely common and extremely complicating factors in our day-to-day management. And then similarly, as Nicole said, it became very evident that we didn't know how to address this. There's no precedent here. We've never seen this before. And so there are many clinical questions that were staring me right in the face that I confronted every single day as a clinician that we had not only did we have no answers to, but we didn't even have a precedent or past history to point at to even begin to try and answer some of these questions. So we felt very, very blind. And that really was what prompted the work that we did.
I wonder if you can kind of expand on this a little bit too, and talk about some of the symptoms and timing of co-benzodiazepine and opioid withdrawal, and how it can differ from just benzodiazepine withdrawal and opioid withdrawal. And maybe you can help clinicians out there. How can they identify patients who might be at risk for experiencing medical complications related to benzodiazepine withdrawal from the unregulated opioid supply, and what makes it so challenging? Why is it such a a challenging thing to kind of do?
So maybe I'll start here, and I'll say those are really some of the key questions that I had daily as a clinician, that we didn't have much of an answer for, and that really informed this Delphi process and this study that we did. Um, the key questions you're asking: how do we how do we identify who's at risk? How do we identify who is at risk for more complicated withdrawal, who perhaps needs more supportive care or a more supportive setting for their care? And in those settings, how do we actually differentiate opioid withdrawal from benzodiazepine withdrawal? Those sound like straightforward questions, but in fact, they're really, really challenging ones. And that was what did lead to this Delphi process and the study that we performed. And there's a few, I think, consensus statements or agreements that the experts came to around those questions. That obviously, anyone who's accessing the unregulated drug supply, at least in BC on a regular basis, anyone who's using unregulated opioids daily is at risk for inadvertent benzo exposure and benzodiazepine tolerance and dependence and withdrawal. Um, we There are certain other factors that you can consider in terms of how much people are using, or whether they're actually seeking out what's called benzodope in our context, or whether they've experienced benzo withdrawal in the past, that might help again kind of risk stratify and guide us in establishing who's at risk. But anyone who's accessing that supply daily is at risk. And then once you're in a clinical setting where you're actually positioned to try and monitor somebody's withdrawal and treat it and differentiate opioid from benzo withdrawal, that was another really murky question that there was some consensus on in this study. I would say that some of the bigger features that help us try to distinguish these two, aside from, again, a past history of having experience with withdrawal, does have to do with the timing of withdrawal itself. And it's felt pretty strongly that opioid withdrawal, especially from fentanyl and short-acting opioids, tends to come on in those first 6 to 12 hours, whereas the more obvious symptoms of benzo withdrawal from this inadvertent exposure do seem to come on a little bit later, 12, 24, 36, 48 hours from last use. So that timing has been, I think, one of the agreed upon distinguishing factors between the two. There are certain symptoms and signs that people may experience that might point to one or the other as well. But there's a lot of overlap. A lot of people experiencing benzo withdrawal and opioid withdrawal at the same time complain of feeling unwell. They feel restless and anxious and nauseous, and they have vomiting, and they're sweaty and unable to sleep. Those are pretty non-specific symptoms. There were a few things that were identified as possibly key symptoms that might be able to differentiate benzo withdrawal from opioid withdrawal, including things like tremors and perceptual disturbances and actual seizures. So some distinguishing factors in terms of the symptoms themselves. But I think the timing has been one of the more, at least in my clinical experience, one of the more helpful guides.
I want to ask now, kind of going in another direction, looking at treating co-benzodiazepine and opioid withdrawal. How is treating this different from benzodiazepine withdrawal and opioid withdrawal? And what are the differences between, say, inpatient and outpatient benzodiazepine tapers? Which setting is recommended for patients experiencing this co-benzodiazepine and opioid withdrawal in your experience?
So the approach for the opioid component of this picture is really no different. The gold standard treatment for opioid withdrawal and for opioid use disorder is opioid agonist treatment with methadone or buprenorphine or other agents that are available in Canada. But those are our gold standards, and really initiation of those medications to treat the withdrawal symptoms, to stabilize cravings, and to help give people some stability and some space to engage in further treatment as needed is still the cornerstone of treatment for opioid use disorder. It's the benzodiazepine component that is the question here, and as I mentioned before, it remains extremely difficult to risk stratify who is or is not at risk for that benzodiazepine withdrawal. So if you have reason to think that somebody is at a higher risk, whether that's because they tell you that they specifically are seeking out benzodope, which is the term that people here use for opioids that are contaminated with benzos, whether it's because of past experiences of withdrawal, if you have a high suspicion, then really that is a patient that we want to try and manage in an inpatient setting where we have that control, that ability to monitor for complications and treat appropriately. So wherever possible, when we are co-managing both of these withdrawal phenomena, again, it was very strongly agreed upon in this work that we did by experts around the province that managing them in an inpatient setting, whenever possible, is strongly recommended. Now, when you are in an inpatient setting, the treatment for the benzodiazepine component of this withdrawal is something that I think most clinicians are familiar with. We treat benzodiazepine withdrawal with benzodiazepine tapers, with scheduled doses or as needed doses of benzos administered in decreasing amounts over time to help kind of ease somebody off of the medication. And those can be administered either through scheduled doses and what's called the scheduled taper, or using what are called symptom triggered protocols. So these are sort of as needed benzodiazepines that are administered often to a protocol known as CEWA, which is again something that most clinicians will be familiar with in other contexts. So there's a number of ways that were agreed upon that these tapers can be managed, really depending on kind of the individual patient and the clinical scenario and the preference of the clinicians. The challenging question, which you mentioned, is what to do in an instance where somebody is thought to be at high risk from benzo withdrawal, and they're either unable to access a withdrawal management facility or inpatient care, or really unwilling to. If you're working with somebody in a rural and remote setting, or somebody who's just really not willing or able to seek out that inpatient care, that is a really, really challenging clinical situation, and one that remains quite murky. The reason being that untreated withdrawal, treating them with opioid agonist treatment without addressing the benzodiazepine piece, puts them at high risk. It puts them at high risk of benzodiazepine withdrawal, of complications such as seizures and confusion, and a much higher likelihood that you're not going to be able to engage them in treatment with the opioid agonist treatment. Conversely, treating somebody inappropriately, if we don't appropriate risk stratify, and we're actually treating somebody who's not dependent on benzos with outpatient benzodiazepines, that we're putting them at risk of other complications, like an increased risk of overdose and like an increased risk of a physical dependency on benzos developing over time. So it's a very, very challenging sort of catch-22, and it's a scenario that I think all the experts in our Delphi study really agreed should be avoided if at all possible. The reality is that this is still a clinical situation that some people need to navigate, and it remains certainly an area for future study, and an area that we still don't have a clear answer on how to address.
Well, you had mentioned earlier in our conversation too that this was something new. You hadn't seen this before, so it seems like the drug supply is evolving kind of faster than the research can keep up with it. So tell me, guys, how do we build evidence and clinical guidance quickly enough to respond to emerging substances and changes in the adulteration of the illicit drug supply?
So I can take a stab at this one. But before I do get into that, I just wanted to also highlight, and I should have said this before when Paxton was talking about symptoms. In our work, we did find consensus on some general symptoms that Paxton highlighted, but we also feature a table of the timelines for symptoms broken down by 12, 24, 48, and 72 hours. And I just want to flag that as being potentially helpful for clinicians. I know that it's not these are consensus from our groups, but it might be useful for those trying to see patterns in those that they're supporting as well. So wanted to flag that and add that in. But getting to how the drug supply is evolving and what we can do, I think we need to strengthen our drug checking system so that we can gain a better understanding of emerging substances and changes to the drug supply in different parts of our province. This is something that we've been fighting for and working a lot with different community groups through our organization, but still more work is needed. And that it's important that we're partnering with people who use drugs and frontline providers. So individuals using substances, peer organizations, harm reduction workers, paramedics, and clinicians are often the first, like Paxton was saying, to identify the emerging trends in the toxic drug supply. And so their observations always need to be incorporated into our evidence generating systems to provide early information on the changing and evolving drug markets. And we could also work on creating more rapid evidence review processes. And this is something that Paxton and I have been maybe whinging about a lot lately, that we could work more on short focused reviews and expert consensus methods that could synthesize evidence within weeks or months rather than years, because often it takes years for our research to get out into public hands, and by that time the toxic drug supply has already evolved. So when evidence is limited, transparent expert consensus like this Delphi process can help provide interim guidance while acknowledging uncertainty. And I think that this would lead to creating a more adaptive research infrastructure that would be more flexible to the evolving crisis that we are experiencing.
Yeah, and I mean, and I would add to that. I think that this is really throwing down the gauntlet for us, and it's about more than just the rapid synthesis of evidence, but we actually have to consider how it is that we're generating the evidence. This is a very this is a problem that certainly extends well beyond BC, the kind of arrival of benzodiazepines in the drug supply. But this is just one of many waves of an evolving drug supply that is changing faster than our clinical guidance can keep up. And whether it's the arrival of fentanyl and us trying to apply our previous approaches for opioid use disorder treatment to a population that has different needs, whether it's the arrival of benzodiazepines, followed by xylazine, followed by medetomidine, we are continuing to see an evolution in the drug supply. It is changing quickly. It is changing unpredictably. And our traditional methods of not just monitoring for that, as Nicole mentioned, but responding to that, are not nimble. We're not able to respond and to generate evidence that applies in the moment, so that we're asking these research questions and generating this evidence that becomes available 3 years later, and the entire landscape shifted enormously. So I think it really does challenge us as clinicians and as researchers to not just be asking how we can synthesize and disseminate and evidence more quickly, but how we can actually go about generating it in real time in a way that's meaningful and can inform clinical decision making now, rather than 3 to 5 years from now, when I can't even begin to predict what kind of questions we'll have then.
Talk to me a little bit about those. What are some of those research questions that kind of came about, and what kind of research studies do you think might be able to address these questions? You're talking about the landscape might change. What are some of these immediate things that popped up that you would like to see solutions to, and how could you maybe find those solutions?
So from this process, we actually, I mean, isn't this how it goes? When you ask one question, you get a number of questions to follow up from. And that definitely happened out of this process. So from this, we also recently published a commentary that focuses on additional research questions from this work, that is forthcoming in Substance Abuse Treatment Prevention and Policy, or actually, I think it might actually be in press right now. So some of the takeaways that we wanted from that one was, how can we effectively test individuals for benzodiazepine exposure and co-withdrawal? So something that kept coming up in the Delphi process was that UDTs, or urine drug testing, can't be ordered to help can be ordered to help distinguish benzo exposure. However, there's limited sensitivity in urine drug testing for many of the new benzodiazepine analogs, and that constrains clinicians' abilities to confirm the exposure. And then there's also some challenges with the effectiveness of drug testing, which depends on the types of benzodiazepines and the types of methods being used. So thinking about test strips versus FTIR machines. So work in BC done by Liang and colleagues in 2024 found that across 159 samples of unregulated opioids in Vancouver, 15.1% contained at least one novel benzodiazepine, with none expected to be positive by the participant. But they also noted that there were false positives, and negative rates were about 15% and 37% for test strips, and 3% and 91% for FTIR, respectively. So while it's good to test, and we're supporting testing, we're still lagging behind on effective testing methods for all of these types. And then while existing withdrawal assessment tools may still be clinically useful, there was also some conversation on using we're not using testing methods that are specifically designed to co-identify benzo and opioid withdrawal. And this is something that needs more clinical support and work on.
So I'd agree with everything that Nicole said there, and I think there's a few different tiers of questions that remain to be answered. First off, I'd say it's important to note that what we did in this study, I think, is really important work. It was work that was really desperately being asked for by clinicians on the ground in BC. But a Delphi study is simply a way of establishing clinical consensus around or expert consensus around questions where we don't have a lot of evidence to inform more sophisticated guidance. And so all of these statements that are being made through this Delphi process, I think, they have some weight to them because they're based on really excellent clinicians and their experiences, but all of them need to be further borne out with empiric data. These are all questions that really do need to be asked and answered around, again, how do we risk stratify people? How do we diagnose benzodiazepine withdrawal? How do we manage it in a safe and appropriate way in different settings? So those alone are still very important research questions. As Nicole mentioned, we asked several questions. We had an enormous amount come back at us, and so there are many other questions that flow from those that really do deserve careful scrutiny and attention. And then, as I've already mentioned, I think it's really important we don't lose track of the forest for the trees, and we ask how do we as a group of clinicians and as a group of scientists adjust how it is that we are responding to this clinical crisis, because it's happening in a way that is evolving at such a rapid speed that our traditional approaches are not keeping up. They will not suffice. And so there are examples on how we can change the way that we ask research questions. While there may not be precedents for this toxic drug crisis, public health crises are not new, and we can look at COVID, for instance, and how did we adjust the way we conducted research in the context of COVID to more rapidly generate results and to more rapidly roll some results out into clinical practice. And there are research approaches that we can modify to do that, and there are knowledge translation techniques that can be used to help do that. But we really do need to, I think, consider how it is that we are performing research when it comes to these specific clinical questions that are changing so quickly, and at a higher level, really recognize that our response needs to be greater. That we really do need to do more if we want to actually have the tools that we as clinicians need to appropriately treat patients in the context of an ongoing public health crisis that, even if overdose deaths are on the decline, is still overwhelming and demands better of us.
It's been a fantastic conversation. I want to thank you both again so much, but I want to shift gears as we come to the close of the show, and I want to ask you both for just a little bit of wisdom and insight. So I wonder if you can tell our listeners, each of you, what advice might you offer to your younger self just getting involved in this crazy field you're in, and those out there who are maybe considering or just getting involved in the field of addiction medicine and this particular field of medicine. What do you wish you knew then? What do you think they ought to know as they kind of get involved in this world, and what wisdom would you like to impart?
I'm again not formally in addiction medicine. I support programming from the evaluation side of things, but I would suggest to people who are in population public health and social sciences backgrounds, you have the skill set to make a large difference. So get out there, learn more, and get involved in your community, and try to dig in deep and find those people that are making changes and support all that work that's happening.
Yeah, well, and I would add to that. I think that I found myself in this work, in this career, not entirely by design, but I think it's an incredibly gratifying, interesting, dynamic, and satisfying world to work in. I love the patients that I work with. I love my colleagues. I think that people who gravitate to this work are just really genuinely want to make a difference, and are fantastic to work with. And all those things I think will continue to hold true. I guess what I would say to myself is that it's not going to get easier. This is a difficult job. It's a difficult time that we're working in, and it can be physically and emotionally draining. And I think that that's likely to be the case for the foreseeable future. But nothing important ever comes easy, and I think it is a really rewarding career path, and one where you truly can make a profound difference in people's lives. And so I wouldn't say that to scare people off, but I think it's just important to come in with your eyes open and make sure that you're taking care of yourself as well if you're going into this work, and that you will keep your own wellness front and center, as well as the work that you're doing for others.
And I kind of want to echo off of what Paxton says too, in that it's hard. The content is hard, the subject is hard, everything is hard. But the people who are in this field, and everyone I've had the chance to work with, care so deeply, and that shows up in the work that's being done.
I love it. Thank you so much for this awesome conversation. What a great way to spend an afternoon. Thank you for your time.
Thank you.
Thanks, Sam.
Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.